So I'm pleased to introduce our next speaker, Dr. Nathan Price. Dr. Price is the Chief Executive Officer of Longevity, a division of Thorne Health Tech. In 2019, he was selected as one of the 10 emerging leaders in health and medicine by the National Academy of Medicine. He is also a professor at the Institute of Systems Biology, where he co-directs with Lee Hood, the Hood-Price Lab for Systems Biomedicine. He is an affiliate faculty at the University of Washington in the departments of bioengineering and computer science and engineering. Dr. Price was previously the co-founder of Aravel, a scientific wellness company. He has received numerous awards. To name a few, he has been awarded a Camille Dreyfus Teacher Scholar Award, is a fellow of the American Institute for Medical and Biological Engineering, and received a 2020 Catalyst Award in Health Longevity from the National Academy of Medicine. So I'm going to turn it over to Dr. Price now to deliver his talk entitled Data to Health in the Post-COVID-19 World.
Thank you for that kind introduction. It's a pleasure to be here. Known you well for many years. Was one of the people that really got me into the field of pregnancy a long time ago, and it's such a pleasure to be here at Magee-Womens, which is one of the really shining places in this field. So I'm excited to talk today because first, it's my first talk back, like for most of us, since the pandemic, and also because I'm going to do something I haven't done in a while, which is present a slide deck that I've never shown even one of them before. So it's going to be the first run here, so I'm excited about that. So I'm going to talk today then primarily about the interface between pregnancy and COVID. And I do want to start with an acknowledgement because basically all the analyses I'm going to show today have been done by Sam Picos, who's a postdoc in our lab. And I also wanted to talk about Jennifer Hadlock, who's an assistant professor at ISB, who's really focused on electronic medical records and was a huge help in all of this project, and Tanya Sorensen, who leads the pregnancy efforts for the Providence St. Joseph Health System. So we're all aware that there are a number of health issues that come out with people that have COVID, with women who have COVID-19 and can have severe illness. And so what we've tried to do is to dive in and try to understand this from a quantitative perspective. So pregnant women remain largely unvaccinated. So despite the fact that we know a number of the dangers, it's also a population that's just nervous about doing things that are new in terms of health often. And so it is one of the lower vaccinated populations that we have at 35%. So we're now far enough in time that we can go back and look through electronic medical records at what has happened to women who have been infected with SARS-CoV-2 in the first, second, and third trimesters, which we've just now been able to start separating that out. And so what we've done is go back and look, and here's the timeline that you can see, basically starting in March of 2020, and then we're going to go forward and look at what's happened through, in this first study that I'll show, through July 4th, 2021. And then the second half of this talk, I'll take you all the way up to about 3 days ago. So what can we learn from EMR analyses here? So one of the nice things about ISB's affiliation with the Providence St. Joseph Health System is that it is the third largest nonprofit healthcare system in the country. So there's a big patient population that we can look at. So we pulled down records from 1.2 million patients that met the criteria we were looking at. Within that set, we had 73,000 women who had delivered babies, 882 infections with SARS-CoV-2 amongst that during pregnancy. And then we had about 17,000 women who had tested negative for SARS-CoV-2 out of that population. And then from that 17,000, we extracted a control set by propensity score matching of 889 women. So basically that let us have a a group that we could dive in and look at what was the difference in pregnancy outcomes if you were infected with SARS-CoV-2 and in which trimester, and if you were not. So in terms of numbers, so in the first trimester infections, we had 85. Second trimester, a little over 220. And then the third trimester, 570. So we have a little bit more from the individuals who were infected later. And that's just because there was a little more time for those to accumulate. So if you look at the women who became infected with SARS-CoV-2, some of these demographics won't be surprising to you. So they are more likely to be minority, more likely to be Hispanic, more likely to be on Medicaid. They trended younger. They had lower educational attainment, higher parity and gravidity. Anyway, you can see all the things up there. And they did tend to have male fetal sex more than female. So if you look then at just premature delivery, it turns out that you do get an decrease in term births associated with SARS-CoV-2. And you can see the numbers here. And what we saw was that it also made a difference. And you can just see from the slant on the, if I have a, I think I have a pointer here. Anyway, you can see from the slant on the bar graph there that basically we saw the least amount of term birth for those who were infected in the first trimester, a little bit less second trimester, less in the third trimester, and then you get up to the full. So that's maybe as you might expect, but the earlier the infection happens in pregnancy, the worse it was in terms of premature delivery. And you can see how that breaks out. I wouldn't read too much into the exact amounts in extremely preterm or very preterm because we are talking about a relatively small sample size there. We also got an increased risk for women who were infected with SARS-CoV-2, we got COVID-19, for gestational age. And in this case, the individual differences between the trimesters is not yet significant at the numbers that we have. But if you just take infected versus not, you get a significant signal in an increase in the babies being smaller. So they are small for their gestational age. There is increased risk for stillbirth and low birth that is associated with COVID-19. And so here the one that really jumps out the most is stillbirth, because we actually saw a pretty significant increase in terms of stillbirth. But you can see from the chart here that you get significant increases in stillbirth. You get increases in small for gestational age, as I mentioned. You do get increases in, or decreases in fetal growth percentile. And you get a decrease, as I'll show in a moment, on birth weight. So if you dive into these data a little bit more here, what we also see is that the severity of the maternal SARS-CoV-2 infection is uncorrelated with gestational days at delivery. So this was an interesting phenomenon from our standpoint in the sense that it did not matter, right, how severe the mother's COVID-19 was. There was no correlation of that in how premature the baby might end up being. And so one of the elements that I found interesting, and I wasn't sure how much to read into this, if you look at the chart on the left, you kind of see a big cloud of points there on the right, and then you see some of these lines that are jutting out. And it made me wonder if there might be kind of separate populations of whether there is some sort of an event that gets triggered, whether it's autoimmunity or who knows what it might be, that if it happens, you have this negative effect, and if it doesn't, you don't get as much of an effect. I don't really know if that's true or not, just kind of speculation. But we did see, and you can see on the right there, that if you look at the severity, you just don't see the fact that the severity is strong early, that's associated with having a much earlier impact on pregnancy. Okay, so take-home points from this first part of the talk. So one, we have an increased risk of preterm birth and stillbirth following SARS-CoV-2 infection. And that's largely driven by infection in the first and second trimesters that have a much larger effect than if you're infected in the third trimester. Earlier gestational age in infection is correlated with early gestational age at delivery. Basically very similar. The earlier mom gets infected, the earlier you see pregnancy. Those things are associated, or you see delivery. The gestational age at infection is the most important feature for predicting gestational age at delivery. And then, as I mentioned, the severity of SARS-CoV-2 infection is uncorrelated with gestational age at delivery. So now I'm going to go into the second talk. Sorry, you see me hesitating because I'm realizing as I'm giving this talk that despite it being 30 slides, it's much faster than I thought. So we might have some extra time for questions. Anyway, so what we've done now is to go through and look at a new cohort. So what's happened, of course, in recent years that we're all very familiar with is the arrival of the Delta variant. And so the Delta variant became dominant in the population. Our cutoff is going to be July 24th, 2021. That's when the Delta variant became over 90% of the infections in the country, and that's shown here. So in this cohort then, what we're looking at is now we're going back and looking at pre-Delta infection with COVID, and that starts in March 5th, 2020, and goes through May 22nd, 2021 is where we cut it off. We then have a middle period that we're excluding from the analyses because that's when there were multiple variants that were mixed up together. And we're going to look at Delta infection, and we'll define that as infection after July 23rd, because that's when the Delta variant became over 90% of the cases, and in fact has gone, of course, much higher than that since. So when we look at this cohort, then essentially what we have is pre-Delta has 942 different individuals, and then the Delta variant will be looking at 265. There we go. Okay, so when we now dive in and look at the demographics that are different in the Delta cohort compared to previous variants, the Delta variant patients were much more likely to be white, non-Hispanic, they're older, they have lower BMI than the earlier infections. They tend to be on commercial insurance. You might remember the earlier ones tended to be on Medicaid, and they also tended to have a higher number of women who had not given birth to a child before. There we go. There were a number of demographics that did not change when you looked at pre-Delta versus post-Delta. So fetal sex, no change, delivery method, smoking status, illegal drug user, chronic hypertension, chronic diabetes, the number of times of pregnant, preterm birth history. These are all things that were not different between the cohorts. Some of the more important ones from a disease standpoint, we have not seen an increase in preterm birth from the Delta that's higher than what we saw without Delta. So that has not changed, at least in these numbers. Stillbirth was the same deal, not higher from Delta than from pre-Delta, and the same with small for gestational age. So when we look at birth weight across the cohorts, what we do see is that there is a lower birth weight that is associated with births that have happened for individuals that have been infected with the Delta variant compared to when they were infected without the Delta variant. So that's 114 ounces compared to 118 ounces, as you can see there, and that's significant at the 0.01 level. So one thing that is very much in a lot of people's minds, and if we harken back to that earlier slide that I showed, right, that only 35% of women are choosing today to get vaccinated. That's as of last week. Vaccinated pregnant people are, in fact, as you might expect, significantly less likely to contract COVID-19. And I show the data here for Moderna and for Pfizer. J&J looks like it has the same kind of trend, but we had many fewer of those, so we didn't have a really good statistical sample of it. So what we find then is there is indeed a very significantly higher risk that you will get COVID during pregnancy, and as I've shown, there are a number of negative consequences to that. So if you look then at vaccinated women are significantly less likely to contract COVID-19. You can see the data here in specific. As I mentioned, we have very few breakthrough infections to look at for J&J. There's a little bit more for Moderna and Pfizer. You can see the significance levels there. So it is a highly significant signal. So with the Delta variant, vaccinated women, and this is what I think is really the most important slide probably in many ways, or finding, which is just if you just take the straight numbers of if you get vaccinated versus not vaccinated. So this would incorporate any negative effect of vaccination if it exists, but just straight up on a choice, if you're vaccinated or not vaccinated, how does it come out? And so what we find is that in fact you're more likely if you are not vaccinated to have preterm delivery, and you can see that that is significant at the 0.0001 level. It's significant in terms of gestational days, right? So the gestational days is smaller. The biggest signal we saw though was in stillbirth, and the numbers are fairly small, but again it is significant at the 0.0001 level, so 10 to the minus fourth. And there what we saw was actually a doubling of stillbirth in individuals who were not vaccinated compared to those who were vaccinated. So it's early, it's not massive numbers, but it is very significant statistically, and it is a doubling of stillbirth associated with the choice to not be vaccinated versus getting vaccinated. Fetal growth percentile is shown there, significantly different as well between those that get vaccinated versus not. Okay, so to summarize, then what I've talked about here is that Delta infections have comparable maternal fetal outcomes as previous variants. Vaccinated pregnant women are about 10 times less likely to contract COVID-19, as you can see. COVID-19 infection severity is comparable in vaccinated and unvaccinated pregnant women, and vaccinated pregnant women are significantly less likely to have a premature birth, and they're half as likely to get stillbirth. So in terms of where we're going, so one caveat I want to give is when I talk about vaccinated versus unvaccinated, some of those things are finalized calculations that we did literally in the last week as we've been working on this as the data rolls on. We will have a paper that we're putting together on this coming out later. The first half was in the Lancet Digital Health, so you can read about it there. I do want to caveat the vaccinated versus unvaccinated because there are differences, of course, in those populations, and we're still now diving through and doing all the statistical adjustments that are associated with those differences in the population. There are factors that pull you both in positive health and negative health directions, so we're not sure exactly if it will amplify or make the signal larger or smaller at this point, but just that is the next phase that we're going through. The other element that we're starting to add on to here is we've gotten access to a massive amount of data on the impact of wildfire smoke exposure during the same period. And so we're looking at the interface now with environmental conditions depending on where you were located, because this cohort that we're analyzing comes from across 7 different states. And so there's an ability to look at some of the wildfire exposures over the last year. So we're folding that data in now. And then we're incorporating additional social determinants of health about patient environment into analyses. So with that, I'm done. And so let me just go through a few of the acknowledgments, and I'll be happy to take questions. So as I mentioned, this work was primarily done by Sam Picos, who's a postdoc in the group. Thanks to Jennifer Hadlock and her group, Tanya Sorensen. I have an acknowledgement in here for Yoel and Oren Barak. That's because I decided in the interest of time to drop the second section, which I shouldn't have done, I'm realizing in retrospect, which is about a big personalized study that we're doing with deep phenotyping in pregnancy called well, we call it the Pregnancy Pioneer 200 after ours, but that Yoel refers to as the DP3 project for deep phenotyping in pregnancy. And that has been a terrific study so far, and I'm sure we'll talk a lot about it at the next Magee Summit. And basically that is an attempt to really look in high detail at several hundred women's trajectories and analyze them from an N of 1 basis with deep multi-omic data that I'm sure we'll talk about a lot more next time. Funding, thank you to NICHD and HHS. And then I also want to thank all the women kind of shown there at the bottom, which have been the pregnancy team in the lab over the last several years. And also a little call out to Allison Paquette, who is really instrumental to a lot of the pregnancy research over time, and who has just recently become an assistant professor at the University of Washington and at Seattle Children's. With that, happy to take any questions. Thank you.
So I have a question. Did you monitor pregnancy losses, not just stillbirths? And between the stillbirths and pregnancy, well, losses might not be able to look at, but were they female fetuses?
Yeah, that's an interesting question. We did not capture as much of the pregnancy loss as we would like to, because so much of it is not captured in the EHR. It was something we considered, but we couldn't figure out a really good way to get enough of that information. You can get a little of it in the unstructured notes, but it wasn't recorded consistently. I don't recall it being really heavily weighted to female fetuses, but it's possible that I don't recall that. I will look in that. Is there a particular reason that you think that might be true?
You said there were more male fetuses born. So the other side of that question is that there are less females being born. So where are the loss occurring? It can't be, because you already know they're pregnant, so it's not a difference in fertilization rate. So you have to account for that negative number. So where did the females?
Well, they could be born healthy, right?
Okay.
They were born healthy at a higher rate under SARS-CoV-2 than were the male fetuses. So the male fetuses were affected statistically higher by the SARS-CoV-2 infection than were female fetuses. We don't really have a reason for that at this point, just an observation.
Okay, I'm going to take a question from our virtual audience real quick. I have a question from Dr. James Roberts. He wanted to know if there was any data regarding preeclampsia in this population. So we do have data on preeclampsia. That wasn't the focus of this particular study. It was one of the other things that we have been looking at diving into and trying to get a handle on. But anyway, for various reasons of scope, we just decided to focus on preterm birth, birth weight and things like that. So we'll look forward to that data.
Yes, we'll need to get a little bit more. There was a little complexity in pulling it out of the EMRs, which is why we ended up not including it.
Thank you. Another question from the audience?
Yeah, it used to be that in order to diagnose or differentiate IUGR versus a small for gestational age, you had to actually cross the standard deviation 3 times, meaning any population be below 3% or above 97% would be the actually IUGR, and the rest would be just small for gestational age, but not necessarily that small. Is there any difference? I mean, when you talk about SGA, is this correlation being taken care of, or is just a small baby by weight?
We actually looked at 2 different elements there, and in the slide that I showed, so on the left-hand side, we showed just the weights and just reported, the shifting in weight that was observed, and that it was significant in terms of SARS-CoV versus not. The right-hand side, where I showed the bars, that was actually using the definition that you're talking about, which is that it was clinically annotated as small for gestational age because it was at the extremes. And in that case, we just counted those up as being in that category. And that's where we saw, and that was significant at the P 0.05 level. So not massively significant, but you could see an increase for women. And we saw it in all 3 trimesters. And as a group, it was significant. And that was with the definition that you're saying, which is that it was at the extreme. So we saw both the shift in birth weight overall, not massive, but was there. And then we did see an increase if you count these extremes of being, calculated as small for gestational age.
Another question from the audience?
Did you happen to have any information on placental pathology in these pregnancies?
We don't have a lot on the placenta in this particular study. It's something that we could try to dig into and pull that out. It's kind of a shame because we actually had a grant with Lou Mugley where all we were doing was studying placentas, which was really interesting. But in this case, I don't know what the placental pathology is associated with these.
So you don't really have any idea of what the extent of maternal vascular malperfusion or fetal vascular
I don't at this point, yeah.
Okay.
It would be another thing to look into.
Thank you.
Yeah.
Another question from our virtual audience. There is a question regarding differences between the Pfizer, Moderna, and J&J. Was there a difference specifically in stillbirths or preterm?
Yeah, I showed that briefly. It's a little hard to pull out just because in our population, people used Pfizer and Moderna way more than J&J. So when we run the raw numbers, we got better outcomes with Moderna and J&J in terms of protection against negative outcomes. But it was a little hard to, but it wasn't statistically significant. What I didn't show on that slide is, we had this impact from Moderna and J&J, or from Moderna and Pfizer. And if you plotted J&J on the same, you can do it, but the error bars were just wildly large, so you couldn't conclusively say it. So it's hard to say much definitive about the difference just because our J&J cohort was really small.
Okay, so if I could just ask everyone to thank our speakers again from this session.